Okay, so I think we are ready to begin now. Welcome to this 56th Pain Journal Club. I'm Dr. Sidharth Verma, and today we are here for a very special topic. And I think this will be quite game changing for some of you who are actually dealing with cancer patients. So today we have some great faculties. I'll just introduce them in a moment, and some awesome speakers. So guys, let's begin. This is the season 2. And as is customary, I'll give a short introduction. Pain medicine world over is got diverse issues, variable standards, different learning requirements, different offerings. Money and time are the major issues which prevent the physicians from learning. And Mumbai Pain School is an initiative of Panisha Spine Wellness and Pain Relief Center to overcome these issues. And we are using social media channels to spread the education and help bridge the gap between the education and practice. And we've got some very good response, following which we have also started on Instagram as well as on Twitter. So we are offering online learning content, which is on demand. We have got both free and paid content. We are having hands-on workshops as well. The next one is in September month. We are very fortunate to have expert faculties from all over the world. It's said that the best teachers, they teach from the heart and not from the book. A journal club is nothing, it's just a club. The basic thing which any club has is that it's a congregation. It's kind of people get together, and here we get together for critically evaluating recent academic literature, which is based on a defined subject. And attendee participation is extremely important. So guys, please feel free to ask questions, comments, suggestions. Everything is most welcome. It is tough to be regular, so try to attend this regularly. And I'm sure this will have very good results. Even Harrison had his own journal club, and which he used for critical evaluation, used to conduct, they say, twice every month. So time and discipline is most important. The papers, especially one of them, is quite lengthy today. So I request both the speakers to stick to their timelines. Healthy skepticism or praise is most welcome. This is a bit about me. I am a spine and pain physician working in Mumbai. But today we have with us some great faculties. So please join me in welcoming Dr. Neeraj Jain, sir. He's a senior consultant, intervention spine and pain specialist across multiple hospitals in New Delhi. And he's very one of the most senior pain physicians and he's also a faculty for certified and advanced interventional pain management techniques in many international courses. He pioneered the non-surgical percutaneous fluoroscopic ultrasound or CT guided pain management intervention procedures in spine disease, fracture spine, cancer, chronic pain disease. He's got a large series of successful percutaneous needle discectomies, vertebroplasties, Kyphoplasties to his credit, including a world record work of 6 level vertebroplasties. Actively participated and interacted with world leaders in pain management at world congresses. So we welcome you.
Thank you, Dr. Siddharth. It is a pleasure to be here. In this academic feast. Always a pleasure. What you do.
Thank you so much, sir. So now we also welcome Dr. Aanchal Sharma. She is MD Anesthesiology from PGI Chandigarh, which is an institution of excellence. She's got her fellowship in pain medicine from Chicago, US. She's board certified from American Board of Pain Medicine. At present, she is working as consultant pain and palliative care at Venkateshwar Hospital, Dwarka, New Delhi. So I think now I'll request Dr. Bhushan to please put up his slides. I will introduce you, Dr. Bhushan. Can you please bring up your Steve slide?
Uh, say it again. Sorry, it's a little. There's a background noise. I can't hear clearly.
Yeah. I think
Okay.
Neeraj sir, can you mute yourself? There is some noise. I think mic noise or something coming from your.
Okay.
Okay.
It may be AC, and I'll just try to switch off AC.
Yes. Maybe, sir. Okay. So, Dr. Bhushan, can you just bring up your CV slide so that I can just introduce you?
Sure. Thank you.
So Dr. Bhushan Thakkar is BPT from India, also MS from MGH Institute of Health Professions, Boston in the US. He is currently a PhD student at Virginia Commonwealth University, Richmond, and he's an avid runner, cyclist, aspiring baker, and coffee lover. His research interests include evaluations of mechanism of pain perception in patients with chronic neuropathic pain to identify and develop targeted pharmacotherapy and neuromodulation based approaches. So welcome, Dr. Bhushan, over to you.
Thank you. Thank you, Dr. Verma. And I also wanted to thank Dr. Aanchal Sharma for her feedback during the presentation and for the slides. I'm happy to be here and present again and hoping to get some questions at the end. Thank you. So my paper today was looking at physical therapy modalities on quality of life in head and neck cancer survivors. It was a systematic review and a meta-analysis. And this paper was published last year in the Journal of Clinical Medicine. And this same group also had a paper that focused on shoulder pain in 2020. And this paper focused specifically on quality of life. So if you all are interested in looking at sort of shoulder pain outcomes, you can also refer to that paper from the same group. So just to briefly go over the introduction, and I'm sure some of you in the audience know more about this area than I do. The head and neck cancer areas typically include, as described in this paper, like the lips, oral cavity, pharynx, larynx, the esophagus, nose, sinuses, salivary glands, thyroid gland, and parathyroid gland. And over the years, with early detection and better treatments, there has been a steady increase in the survival rate of all these patients with head and neck cancer. And survival rate has been at more than 50%. And treatment for these patients with head and neck cancer consists of surgery, radiotherapy, and or chemo radiotherapy. And it's important to sort of note that head and neck cancer typically affects people of working age. So the economic costs associated with this condition are pretty high. And the other issue that the focus of this paper was quality of life, because also that even after sort of remission, there is pain, there are trigger points on the head, neck, and shoulder muscles. There's also hypersensitivity and hyperalgesia, insomnia, and eating problems. And I think one thing that doesn't get a lot of attention is just the body image and the emotional impact of body image because of things that are going on around the face and your head and neck region. So that sort of brings them to the focus on looking at the quality of life aspect of impact of head and neck cancer and the symptoms of fatigue, emotional distress, and how physical therapy interventions can impact these areas. So when they talk about physical therapy modalities in this paper, the two main areas that they focused were exercise and electrotherapy. And with exercise, they were looking at aerobic exercise, typically walking programs, and then progressive resistance training for both the upper body, lower body. And typically they looked at papers that are evaluated like 12-week timelines. And then electrotherapy was focused on using TENS or transcutaneous electric nerve stimulation, and then also laser therapy modalities. So the big picture question with this systematic review and meta-analysis was, are physical therapy modalities effective in improving quality of life in head and neck cancer survivors? And then which physical therapy modalities are most effective in improving the quality of life in these patients? So going to the methods, what they did was they performed a systematic review. So then they performed a search strategy on Medline, Scopus, typical areas where you look for papers, Web of Science, CINAHL, and Cochrane. And then they conducted this review in 2 months between March and April 2020. Any paper that was published till 30th April 2020 was included. in this review, and I'll have a chart that describes the studies that they included in that in their like big review, and then studies that were excluded. So the keywords that they used were head and neck cancer, survivors, physical therapy modalities, quality of life. Okay. So the inclusion criteria was they included only randomized controlled trials. So you need the intervention to be in a control group, and then they had adults over 18 years old considered to be head and neck cancer survivors. And then with the intervention, there was a big list. I'm not going to go into every modality, but these are the common treatments that are typically used as physical therapy modalities in patients in general as well. So both exercise therapy and electrotherapy agent modalities were included in this broad list of criteria. And then they had to have a control group that typically either had a placebo or just the usual care or no intervention. And then the outcome was different self-report measures that focused on quality of life. So they had pretty strict criteria and make sure to involve RCTs and looking at the intervention possibilities with the control group. So the exclusion criteria was, as I said, only papers till April 2020 were considered, and in English and Spanish were considered. So this, I know it's a busy slide, but just want to sort of focus on, they found 251 papers, and then out of that, 174 were duplicates, and they screened 175, and then they excluded another 148 out of the 175, and then they assessed 27 papers for eligibility, and then they performed the systematic review on these 10 papers, and then they included 5 for meta-analysis. And then some of the reasons that they didn't include those 17 papers included just a different patient population. It was a non-randomized controlled trial. There was another active treatment going on, or where patients had metastasis to other areas, or they had other treatments, and if the outcome measures weren't related to quality of life. So this kind of a flowchart sort of gives you a good picture on how and the components of the systematic review and what they did. So some of the outcome measures that they used were pretty standard, and they focused on these 5 that they found. The first one, the European Organization for Research and Treatment of Cancer Questionnaire, or the EORTC QLQC30, was the most commonly used among the different studies, and it has questions on quality of life. It has 30 questions scored on a 1 to 4 scale, and then the other questionnaires were similar in terms of focusing on quality of life, and then either were focused on self-reported issues, discomfort and disability due to oral conditions, or impact on speech, eating, social disruption, and then other symptoms as well. So the focus was on just quality of life, and these outcome measures were validated to be using in this population as well. So what did they find? So they found that 10 studies, as I said earlier, were focused with the systematic review that they found were included in this review. And out of which 60% were focused, or 6 studies were focused on exercise therapy. And they did find that aerobic exercise, which was focused looking specifically at a walking program at a moderate intensity level for 3 to 5 days a week for 12 weeks, was beneficial and significantly better than the control group. And even when you combine that with progressive resistance training, also had meaningful effects. So both aerobic exercise and resistance training, and also combination. And the good part of looking at this was also the adherence. So approximately 93% of the patients that were included in this study sort of participated throughout the intervention for 12 weeks. So that is that's a good sort of a adherence number. So I know this is a busy slide, but I just wanted to show you, when you look at, if you get a chance to look at the tables, or if you've already seen it, it goes into details on how they sort of performed, and they had an intervention group, they had a control group, what was the intervention, what was the frequency of the intervention, what outcome measures they used, and then they measured at different time points, at baseline, at 4 weeks, and then at 12 weeks. And then they reported the differences within groups and between groups. So these were the 2 main studies that sort of focused on the exercise therapy intervention part. And then when you look at the other side with electrophysical agents or electric modalities, they did not find any meaningful effect of using electrotherapy agents. And some of the electrotherapy agents that they found was using transcutaneous electric nerve stimulation, which they said was similar to acupuncture. And then they also found TENS modalities on either the lower limb or suprahyoid muscles. And then even laser therapy wasn't meaningfully significant or had any effect. And one of the important points that they noticed that with the electrotherapy modality is there wasn't a consistent methodological sort of a report. So they, studies weren't consistent on the protocol. They didn't report those how many times did they and the frequency of the treatment. So that's why that was one of these issues with also these electrotherapy modality studies. So this was the paper here that I've just included it. This was a study that had looked at the acupuncture-like intervention. And you can see that some of the issues that if you look at the right side of the slide, they didn't report the mean changes. They did not report any group differences or within the group changes. And they didn't even measure sort of if there was any adverse events as well. So one thing that I really liked about this paper was they made an effort to also look at the risk of bias. And I think when you're looking at systematic reviews and trying to interpret them in your clinical practice, it's important to also go into details to see whether the study was performed correctly and whether it was using all the guidelines. So if you look at this picture here, it describes important outcomes of a study that looks at randomization, that looks at what was the treatment supposed to be given, and then did they include all outcome variables, did they measure it correctly, and did they report all the results. So green is low risk, so that's a good thing. If you have some concerns about the study, then it's in yellow, and then if there was high risk, then it's red in color. So if you look at the bottom, you can see that some of these studies had missing outcome data, and then they didn't give the treatment that they were supposed to give. So that is sort of a concern when you look at some of these studies that were performed and were included in this study. So this is again the same risk of bias, which is showing you like in detail all the studies. When you look at the studies in the middle by Longbro et al. And then McNeely et al. And then Wong et al., they highlight the sort of high risk concerns, which I just mentioned earlier. So coming to the second part of the analysis for this study, where they focused on the meta-analysis. Meta-analysis, they only could include 5 studies, and the 5 studies had combined 182 participants. And then they did find that there was improvement in quality of life after an exercise program intervention. So when you look at this forest plot here, it just does show that the intervention group had a sort of a meaningful change as compared to the control group. So now taking a step back to look at what are the limitations of the studies. And when you look at some of these that I just mentioned, some of the issues with methodology, when you look at the electrophysical agents, not describing the interventions in detail, and then they only found 10 studies, then you could only find 5 for meta-analysis. So that was also a concern where you can only look at the results from such a small number of studies and then a small number of population as well of the number of participants that were included. And then lastly, as I just went over, the risk of bias in some studies was really high. So it is concerning if you are going to use those study results and use it in your clinical practice or take the message home after. So coming to the important point of what can we take from this paper. So this paper performed a systematic review and a meta-analysis, and it identified meaningful benefits of exercise with regards to quality of life in patients with head and neck cancer and the survivors. Electrophysical agents such as electrostimulation and laser therapy had no benefits. It's important to review the risk of bias when interpreting study results. And lastly, the strength of a study was using a systematic review and meta-analysis that included only randomized controlled trials that had an intervention group, that had a control group, and they had used validated outcome measures. So that is the strength of a study like this. So to summarize and bring it home, this systematic review sort of performed the focus on head and neck cancer survivors with regards to quality of life. And I think it's important, especially with this population of head and neck cancer, that you focus on quality of life as well, because of the adverse events of cancer treatment that I just mentioned, and also the emotional impact of body image in these patients. And then studies using electrophysical agents did not find any benefits, and there is excellent adherence and treatments were safe. Most of the studies that they used in this review found the treatments to be safe, and more than 90% adherence was noted to the intervention after the study. And then future studies should also incorporate other aspects of recovery and also sort of focus on what are the changes in pain and what are the interventions specifically in pain as such. So thank you, and I'll be open for any questions or any discussion points.
I think we take the questions together at the end.
Okay.
Will that be fine, Dr. Aanchal?
Yeah.
Yeah, okay. Okay.
Or Dr. Siddharth, the topics are slightly varied, you know. If people have questions, they can go ahead. Otherwise, we can always pool them together. Because we have a very, you know, kind of happening paper coming now, vertebroplasty and kyphoplasty. In cancer. Yeah. We also go ahead. Go ahead.
We are happy to take now as well, but if they're not, we'll take them at the end.
Okay, fine.
So, Dr. Sasmit, you can start sharing your screen and just make it full screen and put up your CV so that I can introduce you. And I think we can begin. Dr. Sasmit Lotliker is MD in anesthesiology, and he is currently a fellow in pain medicine at the DYPU University in Navi Mumbai. So over to you, Dr. Sasmit.
Good evening, everyone. Today I'm going to present on vertebral augmentation techniques, that is vertebroplasty or kyphoplasty, for cancer-related vertebral compression fractures. This is a systematic review which was conducted by Gillian Prawn et al. At Ontario Health Technology Assessment Series. So first we come to some research questions. Firstly, what is the safety and effectiveness of vertebral augmentation techniques for cancer-related vertebral compression fractures in controlling pain, decreasing the opioid use, improving function and mobility, decreasing spinal instability, restoring the vertebral height, and preventing or decreasing kyphosis? Second, what is the acceptability, patient satisfaction, and impact of vertebral augmentation interventions on patients' health-related quality of life? And third, what is the comparative efficacy and effectiveness of vertebral augmentation with conservative care for painful vertebral compression fractures? So basically, the treatment of cancer patients with metastatic disease is very complex, and it requires a multidisciplinary or integrated care approach. 30% of advanced cancer patients develop spinal metastasis, resulting in severe pain, nerve root compressions, and have a greatly reduced life expectancy, such as in multiple myeloma cases. Untreated vertebral compression fractures can result in a range of morbidities, such as irreversible neurological symptoms and paraplegia, including acute and chronic pain and spinal deformity. Treatment decisions for patients with advanced cancer are often based on the general health condition or physical performance status. So what are the aims and objectives of the study? First, to evaluate the effectiveness and safety of two percutaneous image-guided vertebral augmentation interventions, namely vertebroplasty and kyphoplasty. Second, to evaluate their comparative effectiveness with conservative management. So what are the methods used? Literature search was carried out using Ovid Medline in process, and other non-index citations, Ovid Embase and EBM reviews. The extracts were reviewed by a single reviewer, and for those studies meeting the eligibility criteria, full text articles were obtained, and the reference list for any additional relevant studies were not identified through the search were also examined. What are the inclusion criteria? First, English language full text publications. Second, studies which were published between January 2000 to October 2014. Third, reports including randomized control trials, systematic reviews, meta-analysis, and observational studies, including case reports. And fourth, reports which involved vertebral augmentation techniques like vertebroplasty or kyphoplasty for cancer-related vertebral compression fractures. What are the exclusion criteria? Experimental or animal studies which were involving evaluation of technology performance. Clinical reports not involving technical or clinical outcomes. Studies involving vertebral augmentation techniques not performed percutaneously under image guidance. Clinical studies mainly involving patients with osteoporotic or traumatic vertebral compression fractures. Studies which were involving vertebral augmentation techniques performed simultaneously with spinal surgical interventions. And lastly, narrative reviews and opinions or commentaries. So what are the outcomes of interest? Patient satisfaction, pain intensity, reduction, time course and durability, fatigue, sleep disturbances, depression, anxiety, neurological symptoms or neurological status, safety including procedural and post-procedural complications, degree of vertebral height restoration or kyphosis correction, the mobility, activities of daily living and self-care, analgesic drug use and disability related to back pain, and health-related quality of life. So what are the results? The results were basically analyzed under 4 sections, section A, B, C, and D. Under this section A, there were systematic reviews of vertebral augmentation. 14 systematic reviews on vertebral augmentation were conducted for vertebral compression fractures. The procedures done were vertebroplasty or kyphoplasty at single or multiple levels. The various indications included osteoporotic fractures, cancer-related vertebral compression fractures, cancer patient with multiple myeloma, vertical compression fractures due to other pathologies. Section B included effectiveness of vertebral augmentation for cancer-related vertebral compression fractures. Here it was subdivided into first the effectiveness of vertebroplasty. We saw the pain intensity was statistically and significantly reduced from a baseline VAS score of more than 7 to post-procedure VAS score of less than 4. Second, the analgesic use. There was a reduction in opioid analgesic, having 64% reduction in multiple myeloma group and 76% reduction in mixed metastatic cancer group. Pain-related disability and physical performance. The Oswestry Disability Index or Roland Morris Disability Questionnaire, physical performance, the ECOG score, that is Eastern Cooperative Oncology Group scores, and the KPS scores, that is Karnofsky Performance Scale scores, were significantly improved. Also, health-related quality of life and patient satisfaction was improved from 22.1 to 41.8 in both multiple myeloma as well as mixed cancer group patients. Second is the effectiveness of vertebroplasty and adjunctive local tumor control interventions. Here again, vertebroplasty and adjunctive systemic therapy, the overall treatment efficacy of this combined group had a significantly higher as compared to the chemotherapy only group. Vertebroplasty and adjunctive radiofrequency ablation, statistical and clinical significant improvements in VAS scores for back pain intensity as well as pain-related disability scores were seen. There was reduction in analgesic use and prescribed narcotics, and there was significant improvement in both physical performance assessment scores. Vertebroplasty and palliative radiotherapy. Significant pain intensity and opioid use reductions were seen immediate post-op. Also, vertebral body compression ratios and kyphotic angles were significantly improved in both groups over the baseline. Last, vertebroplasty and radiotherapy or nuclear medicine. There was significant improvement in pain intensity, that is VAS scores and KPS scores in combined treatment group. Also, the time to tumor progression and 1-year survival rates were not significantly different between the two groups. Third, we have effectiveness of kyphoplasty. Again, pain intensity was statistically and clinically significant reduced from VAS score of 7 at baseline to a VAS score of less than 4 post-procedure. Analgesic use was also reduced from 91% requirement at baseline to 49% post-procedure. Physical performance showed significant decrease in patients requiring assisted ambulation and also in the KPS scores. Pain disability, again, the ODI scores were significantly reduced from baseline. Also, RMDQ pain-related disability was also significantly improved. Health-related quality of life and patient satisfaction, bodily pain, physical functioning, vitality, and social functioning was significantly improved. Physical and mental health component summary score of short-form health survey also significantly improved. The radiological morphometric outcomes, there was no significant differences between study groups in height restoration in lumbar region, but significant improvements were seen in the mid-thoracic region, especially in the kyphoplasty group. Next is the effectiveness of kyphoplasty and adjunctive local tumor control interventions. First, we have kyphoplasty and radiotherapy. Here, the pain intensity levels reported at 1 month following the treatment for multiple myeloma were reduced to similar levels in groups treated with either kyphoplasty or palliative external beam radiotherapy. Pain-related disability was also significantly improved from baseline at 1-year follow-up in both the kyphoplasty group as well as the external beam radiotherapy group, but not with the systemic therapy group. Vertebral heights were not greatly increased after kyphoplasty, but in 2-year follow-up, heights had stabilized and had not reduced further. Kyphosis measured by Cobb's angle also was significantly improved from baseline. Next is the effectiveness of kyphoplasty, vertebroplasty, and adjunctive local tumor control interventions. Several studies had compared differences between vertebroplasty and kyphoplasty in outcomes of pain reduction, intensity reduction, and reported no difference in pain control. The Edmonton Symptom Assessment Scale showed significant improvements for fatigue, depression, anxiety, insomnia, and well-being. Improvements in physical functioning, that is increased KPS scores, decreased pain disability index, and improved ambulatory capacity was also seen. And kyphosis also showed a significant reduction in mean kyphotic angle after kyphoplasty. The next section is effectiveness of vertebral compression for special or high-risk vertebral compression fractures. Here, it was subdivided into first one, effectiveness of vertebral compression augmentation for vertebral fractures with neurological symptoms, posterior vertebral wall defects, or spinal canal compromise. What are the clinical outcomes after vertebroplasty? Pain intensity significantly improved post-procedure. Analgesic use also reduced significantly, reducing or eliminating the narcotic use. There was improvement in mobility status, more likely in patients with no or mild epidural involvement. None of them had worsening of spinal cord or cauda equina compression. Some patients also had improvements in symptoms of neurological compression. Recovery or improvement of neurological symptoms of cord compression was higher in the combined treatment group as compared to the vertebroplasty alone group. And patients with paraplegia and no motor function prior to procedure had no modification of paraplegia status. Sorry. What are the clinical outcomes after kyphoplasty? Fewer studies were employed for kyphoplasty, high-risk vertebral fractures, and changes in neurological deficits. There was an improvement in the ASIA impairment scale scores from D, that is incomplete impairment at baseline, to E, that is normal post-procedure. None of the patients had any evidence of cord compression. The impact of kyphoplasty on vertebral height restoration and correction of Cobb's angle was significantly decreased in mean percentage of vertebral height body height loss in thoracic and lumbar region. Next, the effectiveness of vertebral augmentation for cervical vertebral fractures. There was significant reduction in pain intensity. There was also patients with cervical level cancer related fractures who required a cervical collar and had difficulty in sleeping no longer required a cervical collar or experienced sleep disruption after vertebroplasty. Significant reduction in opioid use was also seen. Functional impairment, particularly range of motion, was not formally evaluated in any of the studies. Discontinuation of the cervical collar was cited as a measure of treatment efficacy in several reports. Next is the effectiveness of vertebral augmentation for sacral vertebral compression fractures. VAS score significantly reduced 24 hours after procedure. Analgesic use, again 100% discontinuation or reduction of opioids, and all analgesics were seen with 68% reduction in analgesic use from opioids to non-opioids. The measures of pain-related disability such as ODI or the RMDQ were not reported in any of the studies. KPS showed significant improvements. Mobility or ability to ambulate freely, again patients who were formerly unable to walk were able to walk again after vertebroplasty in the sacral and pelvic regions. This was the key outcome measure. C4, we have effectiveness of vertebral augmentation interventions for vertebral hemangiomas. Management of symptomatic and aggressive hemangiomas. Here, vertebroplasty was increasingly used as an alternative or as an adjunctive to surgery. The average estimated blood loss in those undergoing vertebroplasty and surgery was much less as compared to those undergoing just surgery. Also, all reports reported a reduction in pain intensity, although the VAS values were not always reported in vertebroplasty or kyphoplasty studies. None of the studies reported analgesic use. Pain-related disability or mobility scores by any measure were generally not reported, although some studies did report some significant improvement in disability scores after kyphoplasty. The health-related quality of life was measured using vertebroplasty and a significant involving vertebroplasty, and a significant improvement was reported for both physical as well as mental health summary scores.
Dr. Sasmit,
the next section
the pointer. Use your pointer.
Yeah.
Yeah. Thank you.
The next section again, safety of vertebral augmentation for cancer-related vertebral compression fractures. Here, several potential procedure-related complications were reported. First, hematoma. Next, pain at the needle entry site. Third, pedicle fractures. Fourth, infections. Fifth, spinal nerve or cord injury. Sixth, bone cement leakage and migration resulting in pulmonary or cardiac embolism or damage to the vascular system. Asymptomatic bone cement leakage was also noted in this review as a minor complication. Now, first, let us see the safety of vertebroplasty. Here, vertebroplasty for multiple myeloma included complications like asymptomatic bone cement leaks, asymptomatic pulmonary embolism, spinal infection, and disseminated intravascular coagulation. No urgent repair or rescue spinal surgeries or deaths were reported in this group. For vertebroplasty for primary metastatic cancers, the complications included asymptomatic pulmonary embolism, asymptomatic bone cement leaks, hematoma requiring surgery, cement leaks into the spinal cord, causing nerve compression, neurological deficits, as well as cauda equina syndrome. Cement leaks into the vascular system, the respiratory system, that is causing pulmonary embolism and dyspnea without pulmonary embolism, and cardiovascular system causing cardiac embolism, and in which IVC filter had to be placed. 4 deaths were also reported in this group, one of which was because of pulmonary cement embolism, 1 death was because of interstitial pneumonia without pulmonary embolism, and 2 deaths were because of post-op sepsis. Next, the safety of vertebroplasty. Vertebroplasty and adjunctive local tumor control interventions. Major complications reported were bone cement leakage, pulmonary embolism, tumor invasion resulting in neurological deficits. None of the complications required additional spinal surgeries and no deaths were reported. Next, we come to the safety of kyphoplasty. Here, in the multiple myeloma group, the major complications included bone cement leakage, causing pulmonary embolism and spinal cord compromise, and adjacent level fractures occurring 2 weeks after kyphoplasty. Surgery was required in only one of the cases to remove the cement, which was compromising the cord, and no deaths were recorded in this study group. Asymptomatic bone cement leakage was higher in this group as compared to the primary metastatic cancer group. The major complications noted in the primary metastatic cancer group included cardiac complications such as arrhythmias, deep vein thrombosis, adjacent level fractures following kyphoplasty, in which redo procedures was done for the symptomatic fractures, and 3 deaths were reported in this group shortly after kyphoplasty. But all of these deaths were judged to be unrelated to the procedure. Asymptomatic bone cement leakage was having a lesser incidence as compared to the multiple myeloma group. Again, kyphoplasty and adjunctive local tumor control interventions. Bone cement leakage at thoracic level was seen, causing neurological symptoms and asymptomatic spinal stenosis. No surgeries or deaths were reported in this group. In the kyphoplasty, vertebroplasty, and adjunctive local tumor control interventions, the major complications in the multiple myeloma group involved local spinal infections, which are successfully treated with antibiotics. And in the metastatic cancer patients, the major complications included exacerbation of pre-existing congestive heart failure post-kyphoplasty with hospitalization, paraplegia secondary to the progressive epidural metastasis post-vertebroplasty, and laceration of the lumbar artery during vertebroplasty. Again, no deaths were reported in any of these studies. Next, we come to the safety of vertebroplasty or kyphoplasty for high risk or special vertebral compression fractures. First, here we have vertebral fractures with posterior wall defects or spinal cord compromise. The major complications in the vertebroplasty studies involved bone cement leaks, pulmonary embolism, and spinal canal compromise. New or increased pain following vertebroplasty was seen only in patients with epidural tumor involvement. Immediate pain was treated with epidural or intravenous steroids, and delayed increased pain with neuroforaminal epidural nerve root blocks. No deaths were reported in any of the studies in this group after vertebral augmentation for contraindicated fractures. Next, for cervical level fractures, no complications were noted. For sacral level fractures, 3 major complications were noted, mainly symptomatic bone cement leaks involving sciatic nerve, resulting in sensory disturbances, epidural leaks with pain and pulmonary embolism. All of these complications were transient and none of them required any surgical intervention. Next, vertebral hemangiomas. Major complications in vertebroplasty involving vertebral hemangiomas involved bone cement leakage into the spinal canal and intervertebral foramen, compressing the left nerve root and causing leg numbness. Surgery was performed to decompress and remove the bone cement. No deaths were again reported in this group. Asymptomatic bone leaks was also reported in this group. To conclude, procedurally, vertebroplasty and kyphoplasty differ by anesthesia, operators, image guidance, and degree of invasiveness. The choice of procedure was usually clinically based on features of spinal fracture, perceived risk, treatment intent, or operator experience. Both procedures rapidly reduced the pain intensity levels in cancer pain patients with spinal fractures that were refractory to conservative care, usually bed rest and opioids. Also, there was a decreased need for analgesics, particularly opioids, and significantly decreased functional disabilities related to back or neck pain. There were improvements in vertebral heights and kyphotic angles after kyphoplasty, but only for short term. Spinal fractures associated with significant tumor mass require adjunctive procedures like radiofrequency ablation, more often with vertebroplasty as compared to kyphoplasty. Both vertebroplasty and kyphoplasty were associated with a low-risk safety profile. Most common adverse event being bone cement leakage, which was mostly asymptomatic. Currently, there is no sufficient evidence to determine appropriate specific methods of adjunctive procedures or their sequencing with vertebral augmentation interventions for optimal fracture management and local tumor control. The limitations accepted were review objective of some systematic reviews involved only one vertebral augmentation technique, that is either vertebroplasty or kyphoplasty. And the inclusion criteria for some systematic reviews involve study populations having some other pathology or etiology for the vertebral compression fractures, such as osteoporosis. Coming to the critical analysis, small number of RCTs comparing vertebral augmentation fractures to conservative managements were there. Also, there was small number of RCTs comparing vertebroplasty and different methods of adjunctive tumor control. And the role of palliation radiation therapy, either before or after vertebral augmentation, was not systematically reported in clinical studies. The take-home message is both vertebroplasty and kyphoplasty significantly reduced the pain intensity, need for opioid pain medication, and functional disabilities related to back and neck pain, and were also associated with low complication rates. Thank you.
Thank you, Dr. Sasmit. Over to you, Dr. Neeraj Jain, sir, Dr. Aanchal Sharma. Kindly conduct the Q&A session, and if there are any comments, we can, speak now.
Well, nice talk, Dr. Sasmit, and it's a very, very important topic. Dr. Aanchal, you can take things first, and then I'll take over from you.
Okay. Congrats to both the speakers. Very nice presentation.
Just, stop your sharing screen. Yeah, now it's okay.
So regarding the first paper, I gained a lot after reading this paper, because I've been getting these patients, head and neck is one area where the survival rate is more than 50%. And recently I got a patient where the patient was in complete remission, but the quality of life was so down just because there was no saliva, constant dry mouth, and then because of the muscle group was taken for the flap here, so the movement, and she's like, I used to be so active and now there is no cancer, what to do? So I discussed with my physiotherapist whether these laser techniques and TENS, whatever we discussed in the paper, are available in India or not. And it's actually very much available. So, it's just the same TENS, but you use at the different frequency and the different settings. And this progressive training, what was discussed for improving the muscle strength, this goes in a long run, because these patients, goes to surgical oncologist and there's like, we have nothing to do, you're in remission. And every oncologist, they have nothing to do with these patients, but then still the quality of life is hampered. So I think, this is one of the good papers. Patients who do get head and neck cancer survivors on no active treatment and complete remission, and they have symptoms of this disability, these kind of things should be tried from our side with the help of our physical therapy team. And regarding the second paper, I would just shortly answer this question asked by Dr. Rajkumar, and then sir can obviously add up his tremendous knowledge and experience. The Asia score, as far as this paper is concerned, Asia score, for those who don't know, it's American Society Injury Association neurological score. This is just to see the sensory. It's a big chart. You see the dermatomal level, and then it's A and B is complete impairment, like complete paraplegia or complete loss of sensory symptom, and C and D comes to the partial loss. So then as far as if you see that C1 section, table 16 and 17 of this paper, they do mention that if you combine vertebroplasty with other treatments, like for example, this is mostly seen in the metastasis, not like with the just osteoporotic fracture. You won't see the complete neurological loss with that. So in that, if you combine the treatment with local therapy or chemotherapy, there have been improvement in Asia score C and D, which is a partial loss. But in A and B, they haven't seen, none of the studies mentioned any improvement, but there was no deterioration as well. So just thinking that patient is in complete paraplegia, I guess they still went ahead and did the vertebroplasty. So that's not a contraindication for doing it. And then sir can add.
Yeah, and the other reason why we sometimes have to do vertebroplasty for stability reason. You see, if you don't stabilize a given segment, pain is one of the most important indication. Other is the stability. If you don't stabilize a given fragment, the others get at risk, and there is the consequential neurological injury. They can, again aggravate the problem. So that's one reason. Suppose there is only a small scale injury to the neurological symptom. If you don't take it up, it will go into a complete cardiac myosin syndrome or valve bladder involvement also. So you have to take it up at the given time and try to improve upon as much as one can or you can. So that's the whole idea of taking these cases up. And especially in malignancy, see, there are some papers which are mentioning the scores in the normal or control population stayed the same. Now I have an objection to that how can a cancer population which is in a control group is going to be in a static phase, is going to go from bad to worse if you don't take it up in time and treat it proactively. See, the whole idea of doing all this is in a given lifespan of the patient, you try to maximize. You're not trying to add days to life, you're trying to add life to days. The philosophy is straightforward. So you're trying to maximize if you can proactively do something about it. And here is a very, very good technique. And in good number of patients where there is osteolytic lesion, if you take it up in time, do cementing, very good results. Patient is pain free and patient is almost getting drug free thereafter, if you done it at the right time in a right patient, right subset of patients. Well, there would be some patients who would still need some dose, some drug, but on a lower scale, like he really said, Sasmit said, from narcotics they get into non-narcotics. So that's there. But again, be very clear, if you have to use NSAIDs and there is a limited lifespan of these patients, don't shy away from NSAID because it is going to knock off the kidney. See, patient is going to get knocked off before the kidney is going to knocked off. So that you have to calculate. If the kidney is healthy and all, and patient doesn't have comorbidity like diabetes and other things, and you think kidney can survive the patient's lifetime, so it's okay. Go ahead with NSAIDs if it is helping and relieving the pain of the patient. Many times people say no NSAIDs. So I'm against that philosophy. Patient has got a month left and you are trying to save kidney. No, save patients given time. Give a quality of life to these patients and they want to live. Yes, this is the reason why, like you really said, American Spine Injury Society, association, they do all this scoring and all, and they try to maximize. So we are trying to bring patient to the best possible level in a given span. That's the whole idea. That's what you really said. So is the idea. There are few points, I think. I just wanted to say something. There is a word here that there are some reports that anesthesiologists were not counted. One of the paper in one slide says didn't do study on the anesthesiologists doing vertebroplasty. I had an objection to this. Here are the anesthesiologists who are trained pain physicians and they're doing vertebroplasty, so they should be counted in the number results. They took neurosurgeon, orthopedic surgeon, other guys. The other was control group, which I mentioned. They tend to go from bad to worse. So please, we are not supposed to say the control group says at the same level. They also tend to get worse. So we are trying to bring the patient back from getting bad to worse. We are trying to make it bad to good. So that's the philosophy. Another Sasmit said cervical, there is no complication. I think let's not take this message back home. Cervical is very, very kind of a demanding situation for vertebroplasty, and that too in a malignant setting. Please, everybody, be clear. I don't expect people to take a vertebroplasty, and especially in the malignant situation, especially in the cervical area. That should be I think I would rather say, normally we say we do 50 lumbar epidurals, then we take cervical epidural. And especially if somebody is not anesthesiologist per se, who have been doing epidural day in day out, for other people who come and get trained for pain physician like neurologists or other people, they don't take up cervical epidural. It always comes late in the practice. Same way we do endoscopic disectomies, lumbar, and then we tend to go cervical once you're adequately trained in lumbar. Same goes for vertebroplasty straight, period. That you do good number of osteoporotic vertebroplasty to begin with, and the lumbar region or dorsal lumbar region, and then go on to the malignancy or all this kind of cancer setting vertebroplasties, which are more demanding, and at a later date only think for cervical. So cervical, no complication, is okay if they are reported, but I don't want people to take this message back home. It is very, very demanding. So that's very clear. And I have read reports about cervical vertebroplasty. People have done semen leakage into the vertebral artery and into the brain stem, and even the cord, cervical cord. So these are theirs. Another was you said semen leakage. It is known for pulmonary embolism. We know it about it goes into IVC. There are reports of a semen leakage into the renal arteries, renal vessels, which causes hypertension. So they are being lisinopril or other drugs for the hypertension over a period of time to these patients, and they are surviving with that antihypertensives. So it's known to cause even the renal. When the vein comes, the renal comes straight next to that because they're direct supply from the aorta and the IVCs. And there are some reports, people who had the foramen, in the heart, and there is a communication, so they get into the cerebral circulation also. So there are some reports of that. So although mostly are asymptomatic, there have been very few, one death only which you mentioned, but still I want people to be very well aware of these complications which happens. And these mostly happens when the cements are very liquid state. I'll explain after a minute or so, what should be the consistency of cement, how to avoid leakages, especially in malignancy settings and all. I'll explain that after a minute or two. But I'm just trying to dissect upon your paper first. And you said one patient had a paraplegia in the epidural leak. I just want to know, is it instant paraplegia or was it delayed paraplegia, which you said because of tumor migration or tumor progression? It could be instant because of the semen leakage, and or if you're trying to put in the semen inside the vertebral body and you're trying to push the tumor mass backwards towards the cord, this can also cause a compressive myelopathy, instant compressive myelopathy. So these are known things, especially with the ballooning. If I'm trying to balloon inside the vertebral body and there is already mass, osteoblastic mass inside. In osteoclastic, no problem. Osteolytic, no problem. In osteoblastic mass, so we have to have a tumor debulking first, and then we go for cementing. And this is something which I want to know from you. When was this paraplegia, instant or a delayed one? So we have to know the cause and accordingly justify, in a given subset of patients. And one small thing was hemangioma we discussed. They are benign tumors. They are not cancer, by the way. So good, they put that in this paper for the sake of completion. But it has nothing to do with the cancer scenarios. It is benign tumor. But yes, one of the most effective vertebroplasty cementing procedure in the spine, where almost painful, progressive, aggressive hemangiomas can well be taken care with this procedure of cementing, embolization. And some people have done even before embolization cementing, they have put ethanol and other sclerosing agents, and they have done cementing thereafter. So their leakages are reduced, thereafter. But on the same note, I want to say the vertebroplasty was discovered for aggressive cervical hemangioma. If everybody knows about it, I must be sure that is where it was started in 1984 by Dermond and other people in the France. It was aggressive hemangioma, not responding to any kind of treatment, not going for surgery, which could have not helped this patient. So they try to embolize with the semen, and that is where it was really discovered. It is a courageous effort on part of someone, and then it is a history now. There are lakhs and millions of people got cemented. Europe people started 84, but the US people took up in 1993. And that was Jensen in 1993 started in USA, and thereafter USA is doing more vertebroplasty and kyphoplasty and cementing procedures than the Euro people. Others can talk, and then I'll just take it. There are a few lead points for the vertebroplasty, the technical points I can discuss if you have time, or you want to talk something, Aanchal, or some of my friends. Bhushan, you want to say something about it? About Bhushan, your paper, good talk. We are talking about the head and neck cancer, about the physiotherapy and other rehabs and all. Rehab is very important tool for all these cancer patients. Made survivors most important for them, and even if they don't survive, they have the given lifetime. And all this, you see, chemotherapy, radiotherapy, and the surgeries have been done. It is very morbid scenario for those patients, and it's very painful for the patient, and even more painful for the family. See, all this stress and disorders, they come to the family later on. So we try to minimize. That's the whole point. And that's the big role of physio. All this breast surgery has been done, lymphademas and all. Only thing is, it's physiotherapy domain or rehab domain. The surgical part is over, the medical and radiation onco is over. That is the most important thing thereafter, and they have to be taken care. So this is vital. I remember one patient, by the way, it's a side incident. I was coming from Canada to India. On my own flight, one lady, she fell on the floor, and she had some kind of a problem and medical emergency was called. So I went to the lady, and what I discovered, she got a surgery done for the breast, CA and all. She had stockings all over the legs and other things or something like that, and she had surgery done in USA and going back to Germany. She was German citizen. So we had a language barrier, so interpreter came in and they gave us a history. So anyway, we could manage. We knew it's a vasovagal kind of scenario, so not a much of a problem. And anyway, they still, we had to go across the Atlantic, but this time they landed the plane in Halifax in Canada itself, deboarded her, and then plane flew off for the next phase. And then everybody came to me, crew came to me, thank you doctor, thank you doctor. So these things are known. See, this is all to do with the physio part. So it's very, very vital. I think I must emphasize head and neck is one part, is even more important when it comes to the other part of the body, and this is very, very vital. I think we give due respect to those modalities which gives quality to these patients. And in post surgery, corrective surgery, like breast surgery has been done, corrective surgery is done, patient is really howling and crying of the lymphedema and all. And I have seen patients, even they continue disease, and with the same, they say cut my arm, it's useless, but it's not really, it's very, very painful, cut my arm. So these are patients who we should try to help as much we can. So anything, Aanchal and Bhushan friend, then I'll just take a little bit on the technical part of the vertebroplasty in the cancer scenarios.
Thank you again, Dr. Jain and Dr. Sharma. I just wanted to highlight the same points that you all mentioned, and I think also using laser and other electric modalities to like TENS don't have any sort of side effects or any contraindications typically. And I also know when I was in physical therapy school in 2004, 2005, we had laser that was being used very commonly. So I think it is being used. It's just probably finding some physiotherapist who has access to this, especially with laser, because it is so specific and it's like focused on one area, which you can't typically get with other modalities which use bigger areas. So with laser and being the accuracy and use, I think we should use that. And I agree totally with head and neck cancer and with breast cancer. It's more about the emotional impact and the quality of life rather than just because shoulder pain and back pain and upper neck pain always are there, but you can probably treat that, but you can't treat the emotional impact on everybody's life and the family. I totally agree with that. So yeah, thank you.
No, rehab carries with the mental acumen also. It has to work all over. It's all round part of the patient. That's very, very vital. So there are few points I think if you can add for the academic value. I'm just trying to say that we have time.
Yes, sir. You can.
Okay. So very, very small, brief, 5 minutes, just less than 5 minutes. By the way, so it's a very, very good and very advanced topic, Sasmit, because you being a new fellow and you've taken up a very, very big topic, which is the later half of the pain practice. People do it, endoscopy, dissecting vertebroplasty, but took it in the beginning. And very good, Dr. Sidharth. I must compliment you. You've taken a very important, kind of a journal, 202 pages. I have to tell people here, and it entails almost everything about vertebroplasty and kyphoplasty augmentation to do with the cancer cancer patient population. I couldn't even complete those 202 pages. I have to be very frank because it's such a vast, paper, but very, very important paper. And it is thoroughly covered all aspects of the cancer-related treatment in the vertebroplasty and all. The second is about 70% of the patients who are in advanced stage of disease or before death, they have a spinal mats. Beyond lung and liver, the spinal is the most common one as a bony mats where patients got, and very few, about 10 to 20% patients are symptomatic to begin with. They become symptomatic over a period of time. So when they come to you, symptomatic is those 10-20% patients are showing up. There are about 50-60% patients still living with the mats in the spine, and they don't know where the primary is. Many times primary is in a very big question. We are not able to find primary sometime. We do PET scan, other things, but primary is in doubt. So these things do happen sometimes, even in lung and other places. Like you have pleural mats and you're not finding where from it came. So we really have to look into that part. The diagnosis becomes vital. So we have to confirm the diagnosis. There are some issues, like you said, osteoporotic compression fractures and or POTS and or malignant fractures. Now they can be isolated incidences with these fractures, or they can be coexisting ones. A cancer patient may have a tubercular issues or may have an osteoporosis for sure. Obviously they are older age, like breast CA. They are about postmenopausal ladies who got CA breast will have an osteoporosis in the spine, and now they have so many incidences of the osteolytic or osteoblastic mats. So it's in the subsetting of the osteoporosis, patient has got a mats. Now obviously they are going to be symptomatic, and we have to treat. Now we have to treat from both angles, the osteoporotic fracture angle as well as the metastatic fracture angle. So these angles have to be taken care of, and we have to for the diagnosis we do all clinical aspect of it. Radiology is very vital. There's a very big chapter on radiology of the malignant fractures vis-a-vis the osteoporotic fractures. So there are few signs. I'll just elaborate on that quickly. And obviously labs and AI has come. Sidharth, AI is coming in a big way to diagnose these fractures, whether it's a metastatic or the malignant fractures or the osteoporotic fractures. And there are few settings in osteoporotic compression fractures. There is a retropulsion, remember. And in the metastatic or tumors, spinal tumors, there is convex posterior border. So there is a difference in an acute retropulsion or the convex border. That is one good sign. Second is the rest of the marrow would be near normal in the osteoporotic setting, but that's not the case in the malignant cancers or the spine, where the pedicle and the posterior element are very, very often involved. So this is if pedicle and posterior element is involved, it's a malignancy scenario, clear cut. And there could be a paravertebral and epidural extension in good number of patients. One has to look for that. Then comes the fluid sign, which is in the fracture cleavage. You got a fluid sign which is there in osteoporotic setting, but in CA setting there is a halo sign. There is a osteodense lesion and there is a hypotense lesion inside. So this is called a halo sign in some subset of patients, especially all these multiple myelomas. And yes, we do have multiple fractures in osteoporotic setting, but it can happen in advanced cancer scenarios also. So that difference is there. Mostly you take one or two ones or one of them. So that's the sign. And then comes the cavitation. Obviously osteoporosis, we tend to have a cavitation, so we play with this cavity, whether to put a vertebroplasty, put a cement inside, and you can put a little more viscid or liquid cement. But in a malignant setting you have to have a little solidified cement, so there are less chances of leakage, but at a low pressure, very, very important. But in metastatic setting you have to have the cavitation first, make a cavitation first, and then put cement inside. You cannot think of putting cement directly, because then there are about 8 to 10% chances of a cement leakage. So we have to avoid that. And you talk about cement leakages, although they are mostly symptomatic, but they can sometimes be nasty. I have seen the nasty ones, so I am saying so. So that point is there. It's technically demanding, as I mentioned earlier. So we have to take it up at a later stage of the career, especially in the malignancy setting, and do other. And it's a very, very good procedure. I'm trying to say do it. But first train yourself in the osteoporotic fractures, especially starting from lumbar or dorsal lumbar region, and then go on to cervical and the other things. And even in the lumbar region you can do malignant settings. Biopsy is a must, even either you do it before for diagnosis or you do it during the procedure. So it's a must to do a sample before you put in cement. You are not excused if you not taken a biopsy at that given point of time. And then you can do a unilateral, mostly is good enough instead of going for bilateral. Less often you have to take bilateral because it's a very morbid scenario. Pedicles tend to fracture, bone is already in a lysis state, so you tend to be unilateral than bilateral mostly. So that's good enough. You take bilateral only if you are not satisfied with the one needle cementing, then you take the second needle cementing. So this is one thing. And then the biopsy, which I mentioned you. And the reason for this is because you have to see the response to the treatment which is going on. Sometimes they tend to get tumor free, or there is a progression, or there is a new tumor formation, that you have to see. Allied procedure, which you beautifully said, is a very, very important part of the topic now. That all these malignancies, when you do this cementing, you must do all these allied procedures, whether it's a preoperative, peroperative or postoperative. Remember, pre, per, post. Whether it's a RT, which can be pre and post, or there's a very good technique which has come in, is the radiofrequency. So many people are doing radiofrequency tumor ablation or tumor necrosis and proceeding with the cementing on the same sitting or maybe at a later sitting, because you have to do this, and it's very, very effective for 2-3 reasons. It causes neurolysis of the painful nerves, it debugs the tumor. Thirdly, it is said it is taking away the osteoclastic activity which is there. So it is kind of stopping the osteoclastic activities, signaling. And third thing that it does is it thromboses the vessels which are likely to cause the semen embolization or semen leakages. So it kind of thromboses the vessel, and then you go ahead with your procedure of cementing, so it is less likely that it leaks thereafter. So these are few things. And then obviously we have the RF with Kypho, I told you, and it's the other thing is the cryo. Less often we talk about it, but cryo is very useful tool in other places also. When you talk about tumor and cementing, it's not only the spine. We have tumor of the other parts of the body or other bony lesions also, where you do all this, like sacrum, like ilium, or like we even in the ribs. So we do try to combo these things along with the cementing. Yes, it does help. Cyber knife is there, and then you have a stereotactic radiosurgery, and that is adaptive to reduce the spinal cord injuries, because other things may cause spinal cord injury. Because when you're doing these energy measures, we have to safeguard the spinal cords. Sometimes what they do is they run the cold saline or something to save the spinal cord from the temperatures, heating. So this is important. Why it becomes very, and it's very, very important. Put in a catheter, put in a little saline, run over the saline, and then you do the heating part close to the cord or nerve for that matter, just to safeguard it. But you have to do it for the tumor, because tumor and the neural structure can be very close by. So this is to be taken care of. There are microwaves and focused ultrasound beams also available now. Why I'm trying to elaborate is because there's so much of energy sources which are there for tumor lysis, tumor size reduction, and that gives a quality of life and even longevity in some patients. So this is important, and there are few patients who can get cured, luckily, if they are lucky enough. And all this cementing procedure is done. The prerequisite is there shouldn't be any instability, and there shouldn't be any myelopathy, compressive myelopathy. That's the beginning. And they are not responding to conservative management, and there is likelihood of a further deterioration. These are free prerequisites for cementing. Yes, if it comes to me, I am very happy doing a cementing in a patient where I can think I can help the patient. It all depends on the expertise. I told you right from the beginning, expertise. I think this should be it. I think that should be it. I think I talked enough. There are other things I think probably less, like for pulmonary embolism, a word. If there is a pulmonary embolism, if you detected it, the best thing is start in heparin immediately, instant heparin, and put in a long-term anticoagulant, and you can safeguard. Rarely would be a situation where you have to open and take the thrombus from the pulmonary circulation. Rarely would be one. Mostly it is not required. So this should be good. And you already said in the structural nerve block and all steroids, they tend to do well even in the neural foramen leak, but it should not come to the cord. That's the whole idea. Cord should not be compressed, because sometimes you have to do an instant decompression, because patient can have a paraplegia. So these things, claudication or cardiac venous syndrome, have to be taken care. But yes, definitely it's a good procedure. For want of safety of 1% of patients, you tend to still try to do procedure for those 99% of patients where you're trying to help this patient. So the 1% risk is there. Even in cardiac surgery, 1% risk would be there, but we operate cardiac patients. So the same would be the scenario here, I think. So go ahead and do, and I'm happy you took up a very good, nice topic. There's so much to talk. It is by lecture by itself, but I'm happy. It's a journal club, and I think I have to stop here, and a good talk. Very, very good. And again, like Aanchal said, I too learned a lot from your 202 pages. Believe me, I learned a lot. And I must thank you, Sidharth, and you to bring up this paper, because see, for us, learning something new is more tough, because we are already full. So that becomes a problem. But yes, it's never ever a full thing for even at the end of our life, for that matter, because we will be learning, keep learning with time, and more you learn, more you know how much you yet have to learn. So Sasmit, this is important. Take this lead from you, from here, from these JCs. There's so much of science. We are just maybe 50% of it yet.
So, Dr. Sasmit, Dr. Bhushan, do you want to say anything, or Dr. Aanchal, before I move on to the next part?
Just want to thank sir, giving this such a pearls, because I don't think even if like after reading a book about or a procedure, like what kind of cement should be used, whether you are doing malignancy or whether you're doing osteoblastic, and doing a ballooning first or doing a RFA first. Thank you for sharing these pearls. I don't think any books would mention that.
Yeah, we have to really dig so much. So like he made me dig for last 15 days. Thank you, my friends.
Thank you, sir.
Thank you, Siddharth. Thank you, Beta. Thank you, Sasmit. Well done.
So great. Thank you, all of you. Dr. Sasmit, Dr. Bhushan for nice presentations, and Dr. Aanchal and Dr. Neeraj Jain sir for your time and valuable inputs. This is the season 2 of the Mumbai Pain School's Pain Journal Club. And this season, we are focusing on cancer pain and chronic abdominal pain. We are done with 4 journals and 8 papers already. And now we will have a debate next week. I'll just put up the flyer on Sunday. So guys, that will be quite exciting. So I hope you all can join. This season we had a new time. We are more than halfway through, and we had grouped topics for seasons. We had 2 faculties, 2 papers. We discussed papers much in advanced. And as I always say, the secret of getting things done is to act after one of the popular authors. So join our mailing list, guys. I have put up the link in the chat box. The WhatsApp group is also there. Please join that. Suggestions, comments are welcome. Even critical suggestions are most welcome. And this is an announcement about our upcoming hands-on workshop, the hands-on MIPSIs from 16 to 18 September, which will be held in Mumbai. So I'm going to put up the registration links, I think, this week. So those of you who want to join in can register now. So thank you all for joining in. It was very nice talking to you all, and hoping to see you soon the next week for the
Well done. Good one.
Thank you, sir.
My pleasure. Good, Shasmit. We'll talk more about it.
Yes,
Now
sir,
I
sure.
have time to read and go through, so we can share more about it.
Yes.
You get more wiser after the exams, you know. Good. Okay. Okay, my friend.